I think we do have, enough people have already joined that we can get started. We'll start with the land acknowledgement. As we recognize that many Indigenous nations have long-standing relationships with the land upon which we work at the University of Toronto and the Department of Medicine, we acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. These sorts of land acknowledgements are only a starting point for larger conversations. More concrete acts of restitution and transformation are needed to address underlying iniquities and blatant discrimination in the distribution of resources between Canada's First Peoples and settlers. And with that, I think we can get started. And Lisa will be going first. And so it's my absolute pleasure to introduce Dr. Lisa Hicks, a hematologist at St. Michael's Hospital, with an academic focus on health services research and quality improvement. She is the past lead of the Choosing Wisely campaign for the American Society of Hematology and the past utilization lead for St. Michael's Hospital. Dr. Hicks uses traditional clinical epidemiology methods combined with the tools of healthcare improvement to improve the safety and the value of healthcare. And so without further ado, Lisa, please take it away.
Thanks so much, Kaveh. Let's just get these slides up and going. Here we go. So it's really a great pleasure to be able to have the opportunity to share this work with the group today. What I'm going to be sharing is a high-level presentation on a years-long effort at St. Michael's Hospital to address repetitive phlebotomy. This is work that has been done through major collaboration. Many teams of people have been involved in this work. I'll try to acknowledge all of them today, and there's some people who've been very heavily involved who I will call out for particular notice for their help. In terms of disclosures, so I don't have any financial conflicts of interest with this work, and I actually don't maintain any relationships with pharmaceuticals or other industries. I certainly have intellectual conflict of interest. I have a long-standing career focus addressing overutilization in medicine, and that really informs the perspective that I'm coming to today's presentation from. Okay, so before we get started, before I share with you some of the work that we've been doing at St. Michael's, I wanted to say a little bit about the evidence that there is harm associated with repetitive blood draws. There is now a large and growing body of literature suggesting that there is a strong association between the volume of phlebotomy that we collect from our patients and the risk of anemia and transfusion in those patients. Now, of course, most of this literature, and I've called out a few papers here, one of which is one of the very first papers that was done at Toronto General Hospital on the GIM ward. Most of this literature is retrospective observational literature, and that means that it's confounded by the fact that the sickest patients are also the patients who get the most blood work. But there is one very important and recent new trial that is not retrospective, and that is a randomized controlled trial done by Deborah Siegel. This is the STRATUS trial, and I suspect many of you have heard of it. The STRATUS trial was a step wedge cluster randomized trial of small volume collection tubes in the ICU. And in my opinion, this trial really has established the biologic principle that the amount of blood that we're collecting on some of our patients is associated with harm. In this study, they showed that collecting less blood led to a decreased transfusion burden. Now, there's lots of complexities to that trial that we won't have time for today, but that's the big picture. So we think that excessive phlebotomy is associated with harm for our patients. Do we have any data about whether or not the phlebotomies that we're doing in our patients, the diagnostic testing, is necessary or unnecessary? And this is a lot harder to tease apart. What I'm showing you here is some data from St. Michael's Hospital. This is another retrospective study that we did in 2014. It was in admitted patients on the GIM ward, the hematology oncology ward, and a surgical ward. And we looked at a number of markers, measures, trying to get hints of whether or not the blood that was being collected was necessary. So in that setting, we found that more than half of patients had routine blood work drawn for more than 3 consecutive days. We found that patients had a CBC. 36% of patients had another complete blood cell count repeated after 3 stable values. And we found that 26% of patients had a creatinine repeated after more than 3 normal values. This doesn't prove that the blood work was unnecessary, but it sort of gives a hint that there may be some unnecessary blood work we could trim. And I'll tell you that at that time, the average blood drawn for diagnostic purposes in an inpatient was 7.5 mils per patient day. And these are not ICU patients. So this was enough for us to convince us that it was worth looking into this, that there was an opportunity, an improvement opportunity. So we started a traditional quality improvement project, and I want to really highlight that a lot of this work was completed by Dr. Laura Walker. Laura was the chief medical resident at St. Michael's Hospital at the time, and her involvement in this project was really instrumental to its success in many ways. This was a traditional quality improvement project. Our change strategy involved robust stakeholder engagement with actual co-design of the intervention strategies that we utilized. We employed education and order set changes. This is an example of one of our posters, and I'm highlighting it because this was co-designed with residents, which I think was one of the reasons that it was impactful. There's some examples of order set changes, and here we were really going after tests that just didn't make sense on admissions order sets, and open-ended lab tests were another thing that we were really trying to target. So what did we find? We found that before we got started, and this is a process control chart showing that we did achieve a 30% reduction in the volume of phlebotomy blood that was collected, which was statistically significant. So moving from a volume of 7.3 before we started our initiative down to a volume of 5.3 when the initiative was pretty much done, and then longer term data down to 5.1. That was some of the work in the GIM. We got a hint in our work on the GIM ward. We were using administrative data collected from the hospital. We excluded patients who had a stay in the ICU, but we still got a peek at their data. So we knew, we had a hint that there were huge volumes of diagnostic phlebotomy occurring in the ICU, and we were interested in looking in that space. But we knew it would be harder. We knew it would be more complex. The patients are sicker, the stakes are higher, the care environment is much more complex, but we also felt that the potential impact was much larger. So we needed to slow down and really create a convincing burning platform if we were going to go into this space. And here I want to highlight the work of Tom Bodley, who at the time that he started this work with me was a resident in intensive care. Other important partners in this work were Jan Friedrich, Orla Smith, and Olga Levy, and I'll talk more about them as we go on. So we started with a retrospective cohort study. We excluded patients who had major bleeding or only a very brief stay in the medical surgical ICU. And we added on a prospective audit of waste volumes in the med-surg ICU. And this is because our nurse partners taught us that the waste that they pull off before sending a diagnostic sample was probably a really important contributor to the volume of blood drawn from patients. So what did we find? And this is showing the data as it relates to the length of ICU stay. We found that, as the nurses told us, waste was important, contributing 15 mils per day to the volume of blood drawn from patients. And including waste, the average phlebotomy volume drawn from patients in the ICU per patient day was 48 mils. We completed a retrospective regression analysis controlling for age, sex, admission hemoglobin, sequential organ failure assessment score, and ICU length of stay. And we found that phlebotomy volume was independently associated with anemia and with need for transfusion. Put another way, for every additional 5 mils of blood in phlebotomy that were taken, the odds ratio for a hemoglobin nadir of less than 80 was 1.18, and the odds ratio for needing transfusion was 1.17. And I'll just remind you that 5 mils is the volume of a single tube, gold top tube of blood. So this was enough to convince us that we had an opportunity here. And this is when we shifted gears to more traditional quality improvement work. We started our project, which was called Pause the Jaw. And here, really major contributors to this work were Olga Levy, who's an RN in the med-surg ICU and was completing her master's of quality improvement at the time, and Tom Bodley, who I've already mentioned. He led a lot of this work. So the aim of our project was to reduce the average phlebotomy volume per patient day in the medical surgical ICU by 15% by June 30, 2019. Of course, we didn't know that COVID was right around the corner, but thank goodness that was the time frame that we chose. Olga really led a deep investigation into understanding the problem and understanding the workflows. She completed fishbone diagrams, process mapping, she performed interviews, she did focus groups with nurses in particular, and she did a survey. And through this really deep understanding of the problem, we were able to come up with a number of change opportunities. This is the list of them here. Our change strategy focused on stakeholder engagement. And again, not just engaging and not just increasing awareness, but also really co-designing some of our interventions with our stakeholders. We had an education portfolio that we used. We used a lab test add-on strategy. We used order set changes. We used a daily round checklist, and we used audit and feedback. And then we went through repetitive cycles of plan, do, study, act, or what I would more accurately describe as plan, do, study, tweak. I don't have time to go through the full bundle of changes that we introduced, but I do want to call out this one in particular because it was really effective. And one of the reasons it was really effective was that the nursing trainee and MD teams loved it. This was an example of something that improved care. It got us to where we wanted to be, and it also made life easier. It was easier for the teams to take care of their patients. And this was an innovation where we made it easy to add on tests to blood that was already sitting in the lab. Okay, and so what we did to make this easy was we built it into the EMR so that it could be done very easily in the EMR. We taught teams how to do this. And most importantly, we worked with our partners in the lab to reevaluate and extend the testing window for many routine tests so that we could really take advantage of that blood sitting in the lab. So what did we find? This is another process control chart, and I'll highlight for you the major findings. So before this initiative started, the mean phlebotomy volume per patient day in the medical surgical ICU was 41 mils, and this does include waste volume. And by the end of our study, we were able to get it down to 34 mils per patient day. And you can see here the different change strategies when they were introduced and the resulting change that we observed. I'll say that our impression was the rounds checklist we did not think was a successful intervention. It was not well received by the teams and wasn't really done effectively. So it's an example of something that we dropped and changed as we went along. I can show you the same data looking at tubes. So what about the actual volumes of tubes? Not surprisingly, we did, in reducing phlebotomy volume, we also reduced tube usage. And in fact, during the course of this study, it resulted in more than 12,000 less vacutainers or tubes being used. This became really important when COVID did hit because there was a tube shortage at that time. So our ICU was in a better position than it would have been otherwise. What about transfusions? And here what this process control chart is showing you is that there was a trend to needing less transfusions. So the mean transfusion at the beginning, and this is actually this is a U chart, and this is per 100 patient days, was 10.5, and at the end it was 8.1. I say this is a trend, not definite, because you can see that before we started the initiative, the process was not under control, right? So it does mean that we have some uncertainty. We can look at the data another way, which is with pre and post analysis. As a quality improver, I'm not that fond of pre and post analyses, but it is an easy way to understand data. So that's why I've put it up here. And you can see that we did achieve statistically significant changes in the total volume of phlebotomy, the number of unique draws, and red cell transfusions when analyzed in this fashion. Okay, so can we believe these results? This is not a randomized control trial. This is a prospective quality improvement intervention. One of the things I would want to know if I was trying to decide whether I could believe the data is, were the populations the same before and after? And as best we can tell, they were. So here we're showing you that the distribution between men and women was the same, the age was similar, hospital length of stay, ICU length of stay, their mortality, major bleeding events, and the days of ventilation all seemed equivalent. Can we be certain that our interventions didn't cause harm? And this is hard. This is hard to figure out with this type of study. We have some data that we find very reassuring. So our interventions were really targeting these tubes, the gold tubes down. Nothing we did was targeting blood cultures, urine chemistry, or the red tubes. And we see from analyzing our change data more closely that the changes seem to be occurring in the tests that we were targeting, which is reassuring. What's another way of looking at this? What about cost savings? Cost saving isn't why we started this project. This project was really started to focus on harms and reduce harms to patients. But I think when you're trying to sell this type of work, it's important to think about the cost savings as well. You can think about cost savings with regard to material costs or fixed costs. Fixed costs are very hard to change. So the analysis that I'm about to show you is really focused on material costs. So it's an underestimate of the true cost savings. It's looking at lab reagents, the actual tube costs, the sterile syringes that are used when you're collecting blood from an art line, and the vacutainer adapters, so expendables. The estimated material cost savings per patient day in the ICU before we started this study was $32. And at the end of the study, it had decreased, and I actually can't see the number there, to $23. Resulting in an average annual cost saving estimated at about $100,000 per year. You know, it's not massive when you think about huge budgets, but it is something. That brings me to the end of what I wanted to talk about today. I wanted to leave lots of time for questions. What can we conclude from this? Well, first of all, it is possible to reduce repetitive blood draws on the ward and in the ICU. We can conclude that reducing blood draws appears to decrease the risk of anemia and the need for transfusion, and that it also appears to lead to cost savings. I think an important finding is that it is possible to do quality improvement work, improve care, and decrease workload, decrease workload at the same time. And that's really the holy grail of quality improvement work. That's what we want to be doing. We want to make work easier and better at the same time. One of my takeaways is that improvement work takes time. This is years of work. It takes teamwork, huge teams of people. It takes methodologic rigor and perseverance. And then my last conclusion, and this is for the CQIs in the audience, I want to try and convince you that a little bit of clinical epidemiology can really help your QI. And then this is my most important slide. Huge teams of people were involved with this. In particular, Tom Bodley has led a lot of the analysis of this work. Olga Levi was really involved very heavily on the ground in developing the change strategies. Maverick Chan and Vidushi Swarup are research assistants that have worked with us, Jan Friedrich, Orla Smith, and many, many others. With that, thank you very much. This is our goal. We want to move from just-in-case testing to knowledge-based testing. And happy to take any questions.
Thank you so much, Lisa. You could go ahead and stop sharing, and so everyone can see everyone's faces. I think that's just a great example of, we all know that this has been a long-standing problem that affects patients, and we all wish it didn't exist, namely phlebotomizing patients till they get anemic. And it also shows, though, the type of effort that's required, but the payoff that's required that happens. So it's just congratulations on this great work. Are there any questions from the audience? I see Alan has his hand up. Go ahead, Alan.
Thanks. Sorry, I want to get back to, I can't see my face, but hi, Lisa. Lovely to see you. I did send you a personal message in the chat, which I'd like you to look at by yourself. No, it's not for everyone. But Don Redelmeyer and I have a question. Sorry, Don, I'm just going to spill the beans. First of all, this is not Don's question. I think you've shown evidence that educating individual people doesn't work. That the way to do things like this is through systems, and like changing the way you order blood on the computer and changing what the lab does with things like the window for add-ons and adding a system for adding on, which also does depend on people. So I'd like you to comment on the people, the education versus systems part. The other part, this is more a reflection of what Don and I think. I'm a bit disappointed that the savings weren't you expecting more impact? Like 6 cc's, 100, is it $100,000 a year? That's teeny tiny. And I thought this problem, I love that the first reference was Dinesh's paper, which I supervised him on. I think Dinesh works at St. Mike's. I hope he's on the call. I thought it would be much bigger. Are you not disappointed that you couldn't get more bang for the buck here?
So I'll answer both those. I totally agree with you around education, actually. I see education is foundational for change. You need to do education. It's necessary, but completely insufficient. And I think we've known that for a long time. It's where we need to start. But if we end there, we shouldn't anticipate that our change strategies will lead to lasting change. That's my view of QI work and something I take away from this and other projects. In terms of cost, well, I think this is a gross underestimate, right? We could do this analysis in lots of different ways. It's really just looking at the things, some of the material that ends up in the bin. It's no way tackling human costs. And we know that the biggest cost in healthcare is human, right? It's the human labor that goes along with it.
But what about the 6 cc's? Forget about the money value on it. Isn't that a drop in the bucket, so to speak?
Yes, I think it is a drop in the bucket, but there's lots of things we haven't included, right? We didn't include the cost of transfusions. We haven't included the human labor. It's what I showed was a really bare bones cost analysis, really just trying to emphasize that there is some cost savings that goes along with this. And I think importantly that, we went in and did this initiative. We've taken a look at some of the data, and it's the last time we looked, it was sustained. And so those cost savings are also ongoing. But it's the cost one is a tough one, right? To do really robust cost analysis is really tricky. I don't think that's why we do this work, but if we can see, we need to show that there is some cost benefit to what we're doing. I don't know if that's a satisfactory answer. I'm speaking as someone who does economic work,
Yes.
right? There's more to it. This is scraping the bucket. We really did a very simple analysis to try and show that we're on the right side of the ledger.
Plus, as Mark Minden put a comment in too, for another reason why you might have actually underestimated the cost savings. And as you yourself said, Lisa, plus there's the human cost of the lab having to do all these tests and all these sorts of things. So, but it is
There's
good.
this human cost, there's a capital lab cost, there's the laboratory equipment replacement, but all of that is not captured.
Just one other comment in the chat. Greg Choi says, excellent talk, but any concern for unintended consequences? Greg is a rheumatologist here at Sunnybrook, and he worries, I guess, because there's often, pushback about getting these blood tests, but then potentially adverse effects that we might miss when initiating certain agents and so on. I don't know if you have any thoughts on that, Lisa.
Yeah. So that's where balance measures come in that are so important. So, in the work that we did on the wards, I didn't show you, but one of the balance measures we used was stat tests. And did we see any change in the number of requests for stat tests? And we did not. They were absolutely stable. We couldn't use that in the ICU because the lab codes everything that comes from the ICU as a stat test. So that balance measure was no longer meaningful. That's why we drilled down. We did look at timing. So when was the blood sent? So you'll know, most of you will be familiar with the idea that morning blood work in the ICU actually refers to blood work that's sent off typically sometime between 2 and 5 a.m. in the morning. And that's when the bulk of blood work goes. We looked to see if we could see any change in the pattern, maybe suggesting that some additional blood was being drawn. And we didn't observe that. We couldn't see that. I'll also say that the way our strategies were designed, we were really going after things that our stakeholders agreed were unnecessary, that they really felt. So for instance, they told us they had some order sets at the time for patients with electrolyte aberrations that allowed for Q4 hourly or Q6 hourly blood work. And those orders were often staying there, and they were being continued for 4 or 5, days beyond when they needed to be continued because they weren't noticed. And so they were actually asking for us for a way to stop that as a systems level. And we put in a hard stop so that lab work that was ordered with a frequency of Q4 or Q6 could only be ordered for 24 hours. And then a reminder would come up that it was going to disappear and you needed to reorder it. So I think we've done our best through stakeholder engagement, through design, and through balance measures to mitigate any potentially harmful impact of the work. But it's something we always need to keep in mind.
Lisa, I have a question that maybe relates a bit to Michelle's comment, but I'll ask my question. She in the chat, I mean. But what one of the really nice touches in your project was the thing with the new order, allowing people to add on tests through the EMR. I mean, I guess addressing the sad reality that it's sometimes harder to add on a test, and so people will just order more blood work. Did that come to light during the project, the idea that was a problem, or did you sort of know going in?
I'm so glad you asked that because I didn't have time to get into the details. This came to light from an emerge nurse. So it was an emerge nurse, not in the context of any quality improvement work, who raised this issue with the lab and said, we need a way to do this. We need to add on, the hematology team comes down to see our patients and they ask for half a dozen extra things that haven't been done, and I don't want to poke the patient again. So the original strategy came from the emergency nursing team, but it was phone-based and it was only operating in the emerge.
Right.
And then it was the ICU nursing team knew, there's some cross-pollination between those two environments. They knew about that. And so what we really did was make it easy. And the important piece, though, was also extending the windows. And for those of you working in Epic, and we'll be joining you soon, I know that Epic actually allows this. This is a feature within Epic where it's automatically there that you can add. But you might want to go and talk to your lab, because I have learned that I don't think they're using up-to-date lockout times. So you may have a big opportunity there to extend the window, and that was part of the work that we did.
Thanks, Lisa.
And I should say, when we flipped the switch, we didn't just change things in the ICU, right? And so I haven't done the analysis, but this is now widely used throughout the hospital. And those are some of the downstream trickle-down benefits of this type of work.
Thank you so much. Just last comment, which is Michelle Scholzberg comment, other than saying great presentation. She wondered if there's any more further sort of structural or system changes that you're thinking about related to this work.
Yeah, of course, we would like to see the work scaled to other centers. Right now, I think what's front of mind for me is we're shifting to a new EMR.
Right.
And in addition to making gains, we also need to think about loss. And we know that whenever a system changes, whether they're going from paper to an EMR, from one EMR to another, you can lose the gains that you've made before. And so we want to be careful about that.
Well, thank you so much, Lisa, again, for this great presentation. It was a worthwhile project in itself, but also illustrates a lot of the great features when quality improvement works as it's intended. So thank you so much.
Thanks for having me.
And I'd like to now turn over to our second speaker. It's my pleasure to introduce Dr. Brian Wong, who is a general internist here at Sunnybrook, an associate professor in the Department of Medicine, although actually just promoted to full professor. So congratulations, Brian. And also the director of the Center for Quality Improvement and Patient Safety here at the U of T. Whereas Lisa's work was what we would call in quality improvement sort of microsystems work, sort of working at the ward or the unit level and hopefully scaling it within the hospital. Brian's going to be speaking to us more about sort of meso level work affecting multiple hospitals here in the GTA. So without further ado, take it away, Brian.
Thank you very much. And it was a fantastic presentation by Lisa, and just an amazing amount of work that was done over a number of years to affect meaningful change. And actually, I think you're going to see some similarities in terms of some of the concepts around the need to work at systems. And one of the things that I'd like to do is use the Long-Term Care Plus program, which is a program that's been in place now for 4 years and that I've been involved with over the course of the last 4 years, to illustrate some of the principles. So it's as much about the program as it is about some of the principles that I'd like to bring about as part of this presentation. I will just say that I'm a general internist, as Kaveh mentioned, the long-term care setting.
Sorry, somebody's not muted. Could you mind muting your microphone? Not Brian, obviously.
I don't work in the long-term care setting, but it's been a real sort of a meaningful part of the last 4 years to have had the opportunity to work with colleagues in the long-term care setting. And the second thing I'll just say is that I'm not an expert in macrosystem change. And so I think a lot of what I'm experienced or observed over the last 4 years might be insights that you all would have some stronger theoretical underpinnings for. And so I'd love to hear from you during the question and answer when we get to that point. I will say that I do receive some salary support from the University of Toronto, as well as Choosing Wisely Canada for leadership positions that I hold with these two institutions. So just a very sort of quick overview around what we mean by macrosystems. So, from Lisa's talk, I think we heard about kind of micro and mesosystem level interventions. There's the microsystem, which is often, for example, the general internal medicine ward. So each unit within a hospital, for example, will represent its own microsystem, and they have individual teams with their own cultures. And those of you who work in the clinical setting will know that you can walk on from one internal medicine unit to another, and they're quite different in the way they carry out their work, even though they look after similar patients. If you zoom out a little bit to the mesosystem level, mesosystems within our healthcare system often represent systems that cut across multiple microsystems. So these might be the lab, for example, like we heard about before, or pharmacy systems, or we heard about Epic, electronic patient records. And then if we zoom out even more, macrosystem change is really about changing system at the level of an entire hospital, or in the current climate, really around the integrated health systems that are the Ontario Health Teams. And so the talk today will really be reflecting on what does it take, or what might it take to effect change at that macro system level. And so the case study is that of Long-Term Care Plus, and I want to take you back 4 years to the onset of the pandemic, just to give you a sense of the context in which this program arose. And it's really important in quality improvement, we talk about this often, that context is really important to understand why certain decisions were made, why certain changes were implemented. And often we don't account for context in our description of interventions. And so then years later, you wonder, well, why did you choose to do that? Why did you choose, for example, to focus on avoiding transfers to hospital? And this was really why. This was the first report in the New England Journal of Medicine of a long-term care home in Washington State, which unfortunately was the first of, unfortunately, many examples of long-term care homes that were very, very badly affected by the COVID pandemic during the first wave. And you'll see that this was a description of 167 confirmed cases, many of which unfortunately affected residents, caregivers, and staff. And unfortunately, in Canada, and in particular in Ontario, we have the very, very sad reality that we had a very high mortality rate in our long-term care homes in Ontario. But this was juxtaposed against other health system data that was signaling a serious concern that we might overwhelm our acute care capacity to look after people with COVID pneumonia and acute hypoxic respiratory failure. And we were seeing these types of graphs and curves, and what our available capacity was, and what we might be able to do if we ramped up capacity. And I think we heard about availability of masks and ventilators. And so this was the context in which the program was developed. And there was this urgent macrosystem change that was needed to really increase the capacity of providers in the long-term care home setting to provide additional support, so that we could safely avoid transfers to hospital out of that concern that we would overwhelm the system. And this was truly, quality improvement on steroids. If many of you were involved in this program, but other types of pandemic response initiatives. And we tried as much as possible to use, sound quality improvement methodology. One of which is to really use quality improvement tools like Lisa described to really understand the problem, come up with a theory of change, and then develop an intervention. But as we all experienced, we had to do this very, very rapidly. And obviously, when we look back on what we did, had we had more time to do things the way we might normally have done, we may have arrived at a slightly different intervention. And as it turns out, probably quite a different intervention than where we landed. So actually the team at Gemini were able to take the Gemini data set and turn around this analysis in quite literally a week. And what they did was they looked at acute care transfers from long-term care that stayed less than 72 hours to try to understand what were the common diagnoses that were being looked after, what were the care needs of these individuals, and could we provide those elements like specialist referrals, lab testing, diagnostic imaging in the long-term care setting. And then we went about using all of our quality improvement tools, whether it was a run chart or a Pareto diagram or a process map, to try to do our best to design the best possible intervention to be able to implement at scale very rapidly. And so by April, so a month into the pandemic, we launched the Long-Term Care Plus, or LTC Plus program, which was really a hub and spoke model, which involved 6 hospitals and 54 long-term care homes. And that isn't to say that the other long-term care homes didn't get support. In fact, they just had different models of support that those hospitals were providing. But it really was a cross-sectoral collaboration that drew upon expertise from long-term care providers as well as acute care providers. And there was the merging of quality improvement, data analytics, along with clinical expertise to try to build the different components of this program, with the ultimate aim initially of reducing acute care transfers from the long-term care setting. And so, similar to what Lisa was saying, we have to move through this relatively quickly here. So I'll just go through and sort of provide a highlights of what the model looked like in sort of April 2020. And essentially there was a hospital, and so this could be Sunnybrook, for example, or Unity, or UHN. And then there were geographically assigned homes that were linked. And these homes were provided access through a single number to call for a variety of different services that previously had not been readily available in the home setting. So that included a virtual GIM consult, so you could get a general internist on the phone within usually 30 to 60 minutes. There would be a navigator, a nurse navigator available to help long-term care providers navigate the system to gain access to resources. We actually partnered with Life Labs. We did engage with DynaCare as well, but it was only Life Labs that was able to implement very quickly a same-day lab testing in the home across our homes. We put in educational webinars to provide professional development in collaboration with long-term care providers. So these were sort of co-developed sessions with long-term care providers. And then we started to implement some integrated care pathways, like a virtual fracture care pathway, which I could tell you about during the Q&A, but I won't talk about too much right now. And like I said, it was this huge undertaking with all of these different organizations coming together very quickly. And what was really neat to see was the academic institutions partnering with clinical institutions, along with some community-based organizations, to try to hold up this program very quickly. And so we were able to get a CIHR-funded grant, and the PI, Geetha Mukherjee at Women's College, led this evaluation, which was a mixed methods evaluation of the program. And we used quantitative data, which was the transfer rate per 1,000 long-term care beds, as a time series analysis using sort of a U-chart. So similar to what Lisa showed, we also use statistical process control to try to see whether or not our program was able to reduce acute care transfers. And we tried to evaluate the program's influence on transfers by stratifying the data based on program uptake. So we looked at those that used the program a lot, which was 5 homes, and then the rest which didn't use the program as much. And we combined that with, this should be qualitative, I'm not sure why it says qualitative methods, where we use semi-structured interviews at 6 of the 54 homes with varying levels of engagement. And we did interviews with 32 individuals across a variety of different roles, both in the long-term care setting and the hospital, to explore their experiences and perceptions of using the program and some of the factors affecting its uptake. So what did we find? So this is the number of calls that we received, or number of encounters that we provided through the program. And what was interesting was that we did see that the program was used more during the 2 waves of the COVID pandemic before vaccinations were widely available. Again, this is a control chart. This is a C chart, actually, just with the number of calls. And you'll see that this is the center line here. These dotted lines are 3 standard deviations, and the red dots really indicate instances where there's what's called special cause variation, or one might say that's statistically significant, in sort of ClinEpi language. So we did feel that the program provided some degree of benefit during the COVID waves, just by virtue of the fact that the providers were reaching out more frequently. However, when we looked at actual transfers, we saw an interesting signal. So right where my arrow is showing, you'll see that that is where the program was implemented. It coincided actually with the start of the pandemic. And so the question is this significant reduction in emergency room transfers a result of the program? And I think if you didn't have a control group, we'd be saying that we reduced acute care transfers by 30%. The program was a raging success. But unfortunately, actually, the low uptake homes showed the exact same pattern. And in fact, there was no difference between groups in terms of the reduction seen. And in fact, we postulate that these were secular trends that were attributable to the broader effects of the COVID-19 pandemic. Many people in long-term care did not want during those times to necessarily be transferred for a variety of reasons, including mandatory isolation period upon return. And in fact, sometimes you will remember some people couldn't even return for a period of time during some waves of the pandemic. But our qualitative results would suggest that there were still some perceived benefits beyond acute care transfer avoidance. The providers in long-term care felt supported by providing care that was aligned with their residents' goals and wishes. They felt that they received clinical advice on instances irrespective of whether acute care transfer was being considered. And in fact, oftentimes transfer was not a consideration. And those were the instances where support and guidance were particularly helpful, because these were not situations that were normally looked after in the long-term care setting. Often they would go out to the acute care setting. And it really did strengthen relationships between the providers working in long-term care and acute care. But there were a lot of barriers to program use. There was variable awareness of the program, and that was made worse by the high staff turnover rate. I think at one point someone said that there were something like 30 to 40% of the directors of care had turned over in the last couple of years in long-term care. So, just even awareness that this program existed was really challenging. It was very much dependent on the provider having motivation to access the program, and it was the program's ability to be used was very much dependent on the available resources within the home, and those were quite variable. Some homes had a very robust medical model, others less so. Some had better nursing staffing, others less so. Some had better access to equipment, others less so. And then finally, one interesting finding was that there was a feeling that there was a lack of integration with other available services. It was sort of like, one group was coming in to do this thing, another group was coming in to do that thing. We didn't know who to call for what, and sometimes it was hard to know even if who's going to answer the phone. And so this lack of integration was really challenging. And so what we saw was there was just variable uptake. This is essentially, kind of a bar graph, but you could call it a Pareto diagram of sorts, but essentially just shows that there was a small number of homes, 5, that actually requested 60% of the encounters. So there's just no way that you're going to be able to see an improvement in transfers when your program intervention fidelity is suboptimal. And so the question is, are there approaches that we need to adopt beyond traditional, PDSA microsystem approaches that could address macrosystem change? And are there different ways of leading this work? And I would argue it's similar to what Lisa said around education. I think PDSA and quality improvement methods and mindsets are foundational. You can't do macrosystem change without it. But I think in addition to addressing process change, we need to, and I think this came up in Lisa's presentation as well, attend to the underlying structures that actually give rise to the outcomes that we observe. That if we focus primarily on process improvement without actually attending to some of the structures and modifying them, we run the risk of seeing what we saw in the early days of Long-Term Care Plus, which is a lack of uptake of the program and a blunted impact on the outcomes that we were hoping to impact. And so what would be a structural change that could be very helpful? Well, actually, when you talk to the long-term care providers in one of the homes in the North Toronto OHT, they said, you know what, we have to call Sunnybrook for Long-Term Care Plus, but we call Michael Guerin for the nurse-led outreach team. And for those of you that don't know about the nurse-led outreach teams, these teams have been in place for 15 years. And these are nurses, often emerge nurses, that go out to the homes. They form relationships with providers, and they actually provide skilled nursing care, like Foley changes, wound care, and a bunch of capacity building. And these nurses were going out to the homes during the pandemic, but in sort of a siloed approach to the Long-Term Care Plus program, because they were working in different hospitals. Oh, and by the way, actually, I have to call a 3rd hospital if I want to get my infection control support, and a 4th hospital to get palliative care support through Sinai. And so how could you possibly improve care when the providers of these external support programs rest in 4 different hospitals? Instead, what you would want to have is a home on the left-hand side, be able to call a number and be connected to a hospital that provides all of these services, right? And that this would form an integrated care network that would allow for collaboration, not just between the hospital and the home, but that the services within the hospital could start to integrate themselves. But at baseline, a year and a half ago, only 21% of the long-term care homes in the city of Toronto had that configuration where they could go to a single hospital and get just these basic services, LTC plus, a nurse-led outreach team, or infection control. And so Ontario Health actually, in early 2023, funded the integration and expansion of support services. And the primary ones were long-term care plus and NLOT, such that there was now a scaling up of the program across 8 hospitals, involving now 75 of the 84 long-term care homes and 14,000 long-term care beds. And essentially, what we saw was a launching of the LTC Plus program at Michael Garron and Scarborough Health Network, establishment of new nurse-led outreach teams. So they did not draw from the existing ones. They left the existing ones in their current configuration and added net new teams at the 4 other hospitals. And as such, 100% of homes from 57% have access to LTC Plus. 100% of homes have access to nurse-led outreach services, and 100% of homes now get their care from the same hospital. So this was a massive undertaking, but that was a major restructuring of the support services that were available to homes in the city of Toronto. We also established a data infrastructure to be able to capture data around the care encounters that were being provided. And I won't go into the details, but this was a massive undertaking where essentially providers at the hospitals, whether you were a navigator, a nurse working for the nurse-led outreach team, or a physician, enter data into a REDCap survey. It's the same survey used across the region, and all that data flows into REDCap. And so we have data that suggests that the data is entered in near real time. So the average time to data entry from the clinical encounter is usually 72 hours. We have immediate access to the data. So for example, to prepare for these rounds, I actually got the data from 2 days ago to be able to have as up-to-date information as possible. And that data is then used for reporting purposes, improvement purposes, and evaluation purposes as well. And then we've also established a collaborative that involves hospital-based leaders, long-term care leaders, and the hospital hubs themselves have also built relationships with homes. And so what have these structural changes been able to impact over the first 12 months? And I'm just going to give you a very quick overview of a few data points that I just got access to a couple days ago, and then we'll open things up for questions. So here's a run chart. And this is a run chart of the long-term care plus encounters. And you'll see that within a year of implementing these changes, there's been a significant uptake of the long-term care plus program, much more widespread use of the program. And we've seen evidence of both spread and scale, okay? So this was the original bar graph that I showed you on a different axis, because now we've seen much more use of the program. 39 new homes have accessed the program at least once during this past year, and 22 of the 28 homes increased their use in the last year. And so this is a significant increase in the program's use through both spread and scale. There's a lot more data that we have access to that I'm not going to share today because we haven't had a chance to analyze it, but we're very excited to dive deeper to understand what were some of the drivers of this change beyond the structural elements. And so I'll just quickly conclude that my kind of last minute, last slide reflections on what are some of the enablers of macro system change. I do think it's a combination of local process improvement activities combined with changes to the underlying structures that give rise to the outcomes. This idea of co-design, and Lisa mentioned this as well, that draws on the perspectives and clinical expertise across sectors. I really do think this is a really neat example of collaboration between clinical, academic, and government organizations. And it really was, I think, built on a foundation of relationship building and trust. And similar to Lisa, I didn't list all the names, but I do want to thank all the clinicians, providers, resident caregivers, managers, administrators, researchers, policymakers, all these individuals that were involved in fostering the growth of this program and really creating for me what was a silver lining of a very difficult pandemic. Thank you very much, Kaveh and Arno, for the opportunity to speak, and I'm happy to take some questions.
Thanks so much, Brian. That was terrific. I mean, I think everyone who's been a doctor for a while can appreciate like what it takes to put a program like this together. Like it's so hard to get anything, even a new order set approved at a hospital, never mind to have like a dozen organizations, like from the ambulance service to mobile x-rays to hospitals and LTCs collaborate on this program. So it's just really, really, really terrific. Alan, it looks like you have your hand up. Go ahead.
I do, but I don't have to go first. Are there things in the chat?
Mostly congratulations and a couple of
Okay,
comments. So go ahead.
great. Well, this was a lovely bookend to Lisa's, because hers was indeed I guess you called it a meso system, or was a local thing, and yours was much more to do with systems. I just want to underline what you closed with, which is that all of these kinds of changes depend currently on people. Even though I was emphasizing in Lisa's case that it was the system that affected the change in blood draw ordering, but it was the people that enabled the systems to be able to be created. And there's an excellent article, Elizabeth Toll and Christine Sinsky in JAMA Internal Medicine, called "The Deep Work of Medicine," which is about building relationships on trust. And if you don't have a group of people that know each other and that trust each other and that have experience with each other, then you can't get anything done. And the converse of that is there are often people that have individual great ideas and they can't execute them because there are too many people between them that have their hands on the levers, between them and the rational solution. There's an old saying that I'll give you, Brian, which you can use and which you can steal from me, which is, why did it only take 9 years from the time John Kennedy stated the goal of putting a man on the moon, a person on the moon, it was a man on the moon? Why did that only take 9 years? And the answer is because there are no people between here and the moon, that people both can help you, but they often can get in your way, particularly when you have all sorts of risk management people, like Mike Freilich's example of trying to get rid of the e-learning modules that are repeated for residents over and over and over again. That was a people problem. We couldn't get any people to be engaged. So I think that is, of all the things you said, that is the most important thing, that you can't affect any change without relationships and people, but people sometimes get in the way.
Thank you. I mean, I won't say much more than the fact that I do agree that, and the relationships that we've developed have been long lasting. I mean, these are individuals that work in long-term care that I only knew by name because they were on the discharge summary that I would sign, you know, and now I know them by name. We can text each other. We've had, you know, I had coffee with one of the providers the other day, you know, because we now see each other as colleagues and truly, in some ways, in some cases, friends. The other thing is that to mobilize all the internal medicine teams to be willing to provide virtual consults, for sure, is based on relationships that we have, or I have, with, you know, the general internists across the city who really stepped up and have continued to support the program. Thanks,
Brian and Alan. Francis Shepard.
Yeah, I would just like to emphasize the importance of having the nurses as part of your team and the nurses at the other end of the phone. We in our lung cancer program have a triage system where a nurse sits in our clinic in a special office 9 to 5 all day during the week as a triage nurse. And she's able to provide wonderful information and direction to our patients and really takes an enormous load off the doctors and the doctors' offices. They're knowledgeable, they're helpful, the patients know them. And I think we need to mobilize and bring our nurses into the teams even more than we do now.
Thank you. I didn't say this, but actually the vast majority of the long-term care plus calls are now nursing calls. And they're often the NLOT nurses noticing something on the ground because they're in the setting working with the providers, reaching out to the navigator, who one of the navigators is actually on the call today, so it's nice to see you. And then the navigator working within the health system to try to find solutions for these folks. So I totally agree. Thank you for raising that, Francis.
I think we have time for at least one more. I can see you're not Maria Zorzito, but if you want to go ahead and ask your question,
I am.
Oh, sorry, you are Maria. Sorry,
am.
I'm sorry.
I'm
I'm
here.
sorry, Maria.
No, I wanted to ask, what are your thoughts? Do you think that COVID, the crisis of COVID, really helped to eliminate some of those barriers that Alan Detsky was talking about and sort of facilitated this cooperation? Do you think it would be easier to do it, post-COVID or pre-COVID? Or nobody even thought about it then? I don't know.
Well, I mean, I think there were some groups thinking about it. I know Women's College had already started to work with a couple homes in 2019 to implement like a aging at home strategy. So, and this idea of providing external supports is not a new one. But I do think that COVID accelerated the building of relationships. And I think a lot of that work was led by our infection prevention and control teams who were really on the ground. And I know some of you on the call also, stepped up to provide whatever support could be provided during those very early days. So I do think those relate. But then as the pandemic unfolded, caregiver restrictions, visitor restrictions, and other stresses on the long-term care sector, like staffing shortages, the need to vaccinate at scale, those also served as potential barriers, I think, at times for engagement. I think now what we're seeing is we're able to draw on those relationships, and it's been really exciting to see how the hospitals and the homes are genuinely starting to work together to co-create the changes that are needed. And I see this across all the different hospitals involved.
One last question from the other speaker, Dr. Hicks.
Thanks, Kaveh. Congratulations, Brian. I mean, this is great work, and I can see that it's going to continue, and we're going to hear more and more from you and the team. I'm wondering about measures. I'm sure you've thought about this. It seems you showed measures that were really about uptake, and then that early measure, which was transfer. I wonder what you're thinking. Was that the right measure? What are your thoughts around how you can continue to evaluate the impact of this program?
It's a great question. I think it's a complicated one because I think transfers, like many of the quality improvement measures we have, whether it's readmissions, whether they're challenging because some are needed, some maybe are potentially avoidable. Even the ones that are avoidable may require Herculean efforts to avoid them, and so is that really feasible or realistic? I think what we've been trying to kind of convey is that transfers are one metric. But I think an overemphasis on that metric could lead to the unintended consequences of implementing changes that put at risk other important outcomes like resident experience, like access to care, and access to the types of care that are needed, not just to avoid a transfer, but just to get basic care, or to have their conditions looked after. And so I think what we're trying to say is that it's a yes and. Yes, we're going to look at transfers and avoid them because we know there are downsides, but to also take stock of other measures like palliative care in the home, for example, access to clinical services when needed, and those types of measures. And it's really complicated because obviously the one that gets attention of the funders is transfers, right? So we can't ignore it, but can we work with that to build the program to meet the broader needs of the residents and providers in the homes?
Well, with that, I'll say thank you so much to both of our excellent speakers, and then also to everyone else for attending. Thank you, and have a great rest of the day.